Welcome back to part 98 of our 100-part CPC exam series. Before we dive into today's explainer, make sure to like, share, and subscribe to Decode Healthcare with Harshal. Today, we are jumping straight into a high-stakes compliance masterclass, setting the stage to completely demystify some of the most high-stress regulatory topics using rapid-fire case studies.
We've got a packed agenda today. First, the NCCI modifier decision tree, then global package post-op rules, followed by ABN liability, Stark Law versus anti-kickback, and finally, a quick summary cheat sheet.
Let's get right into Section 1, the NCCI modifier decision tree.
Picture this exam scenario. You've got a surgeon performing a complex primary procedure. That's your column 1 code. But right alongside it, on the exact same day, they do a secondary procedure, your column 2 code. You check the NCCI edit table and boom, it shows a modifier indicator of 1. So, what is your next move? Can we legally unbundle these?
The difference between a 0 and a 1 is absolutely crucial here. A 0, that's a hard stop. It means unbundling is completely illegal, no matter how flawless your documentation is. But a 1, well, a 1 opens the door. It tells us unbundling is perfectly fine provided you can prove it was a distinct clinical scenario and you append the correct modifier.
When you are under the gun during the exam, rely on this 3-step survival guide. Step 1, check that indicator. Step 2, dig into the medical record to confirm we're dealing with a distinct anatomical site or a totally separate session. And Step 3, append modifier 59 or ideally a more specific X modifier to that column 2 code. Speaking of those X modifiers, CMS actually prefers them over the generic, highly scrutinized modifier 59. You definitely want to memorize these for the test. Think XE for a separate encounter, XS for a separate structure, XP for a separate practitioner, and XU for an unusual non-overlapping service. They tell the exact story of why the service is distinct.
All right, moving right along to Section 2, Global Package Post-Op Rules.
Here is your next scenario. A patient heads back to the operating room during their 90-day global period. How do you know which billing modifier to choose? The golden rule here is figuring out the why. Was this return trip an unexpected complication, or was it just part of the original surgical master plan?
The logic splits beautifully right here. Modifier 78 is your go-to for sudden complications, like, say, post-operative bleeding that suddenly requires a washout. But modifier 58 is a totally different ballgame. You use 58 for a prospectively planned, staged, or much more extensive procedure.
Now, what if the patient simply walks into the office 30 days post-op for something completely unrelated? Imagine a patient recovering from cataract surgery who comes in complaining of a sore throat. For that totally separate issue, you are going to use modifier 24 to ensure that evaluation and management service gets paid.
Let's keep this momentum going with Section 3, ABN liability and modifiers.
Imagine a Medicare patient getting a screening test that routine benefits just don't cover. The catch? The practice completely forgot to issue an advance beneficiary notice, or ABN, before the service. Without that signed piece of paper, who actually foots the bill?
You do not want to mix these up on test A. Modifier GZ means the practice messed up. There's no ABN on file, Medicare denies the claim, and the practice literally eats the cost. You absolutely cannot bill the patient. On the flip side, modifier GA means a waiver was properly signed and financial liability safely shifts over to the informed patient.
This brings us to Section 4, Stark Law versus the anti-kickback statute. These are the absolute heavy hitters of federal compliance.
Think about this for a second. Is pocketing cash incentives from an imaging facility for MRI referrals the exact same violation as referring a Medicare patient to a clinical lab that you actually own a piece of? Both will land a physician in incredibly hot water, but you've got to know exactly which federal law targets which behavior.
Here is the breakdown. The anti-kickback statute is a criminal law. It goes right after bribes and cash for referrals. Stark Law is different. It's a civil law that strictly prohibits physicians from referring patients for designated health services to any entity where the physician has a financial or ownership interest.
Almost at the finish line. Section 5, the summary cheat sheet.
Let's lock this all in. Unplanned return to the OR? Boom, modifier 78. Planned return? Modifier 58. Got a properly signed ABN? That's modifier GA, patient pays. Forgot the ABN? Modifier GZ, the practice is liable. Use these rules as your ultimate mental shortcut when you're racing against the clock.
If you can consistently apply this if-then logic, you are going to absolutely crush these dense regulatory topics on exam day. And that wraps up Part 98. But don't slow down now, because in Part 99, we're kicking off the CPC exam Final Sprint Part 1, High-Yield Strategy, Time Management, Book Flagging, and Tab Navigation Hacks. You definitely won't want to miss it. See you there.